Thank you very much, Dr. Brodman, and thank you for inviting me to speak today. My name's Narayan. I'm an interventional radiologist at St Thomas's. My disclosures, and I should also add to this another disclosure: I've spent far too many hours of my life picking out embolus from tibial arteries and trying to get aortic endografts of calcified iliac vessels. So what are the hurdles for endovascular therapy in calcified CLTI? They're the intraprocedural hurdles of flow-limiting dissection, distal embolization, acute recoil, and a very high risk of bailout stenting. Often in CLTI patients you have a suboptimal runoff, and I don't like to be forced to stent when I don't want to do that as a primary procedure plan. Post-procedure, we're at risk of subacute recoil, poor uptake of anti-restenotic drugs, and managing in-stent restenosis when we do have to stent in a difficult situation. So let me show you some cases here. It's very rare you get the opportunity to control your own work in the same leg and the same lesion, but this is a 59-year-old patient who presented to us first in February 2019 with rest pain in his left foot and a few small ulcers. He's a type 1 diabetic and he's had a renal transplant before. You can see the amount of calcium here on the angiogram, and you can see this kind of focal, tight calcified stenosis. What did we do in 2019? Well, we crossed the lesions and we used a rotational atherectomy and did a plain balloon angioplasty, a drug-coated balloon angioplasty, and what are we left with here? We're left with a filter that's full of embolic material. We're left with trash in the perineal arteries. So you know how this story goes. Lots of difficult tibial work, some thromboaspiration, some angioplasty, and finally we managed to get this patient off the table with a decent runoff. The same patient presents to us 2 years later with new occurrence of rest pain in the same foot. He's got a fourth toe ulcer with pus expressed from the wound, and you can see here the disease has essentially recurred in exactly the same place with exactly the same severity, but now we have IVL available. You can see on the intravascular ultrasound pictures how calcified this disease is, and you can understand how this is going to respond to plain balloon angioplasty, and we know how the atherectomy story ends from the previous procedure. So we used the intravascular ultrasound to size accurately for the procedure. As has been mentioned before, it's important to oversize the balloon correctly to get good wall apposition. You can see the Shockwave balloon expanding without any additional inflation, which means that the Shockwave pulses are breaking the calcium and changing the compliance of the vessel wall. We see a plain balloon angioplasty and a drug-coated balloon angioplasty, and we end up with this IVUS image, which shows a greatly improved luminal gain, an excellent flow on the angiogram, and no trash at all in the tibial vessels. I'm feeling very confident. We've got time on our hands. The patient's feeling good, so we move on and treat the tibial lesions as well with the tibial IVL catheter. Again, we end up with this very pleasing result. The clinical story of the patient: his rest pain is gone, the ulcer's dried out, but he has osteomyelitis, so we have to take away the fourth toe, and his fourth toe amputation wound is now healing well. Is the acute result better? The Disrupt PAD results from 30 days suggest yes. Is it more durable? Well, we're going to find out next month what the one-year results from Disrupt PAD 3 trial are. I can tell you one thing: it's definitely less stressful for the patient and for the operator. And what you can see here from this Disrupt PAD 3 data is that the results it's very predictable between the RCT and the observational study, where all comers have been treated, that the safety profile of this device is excellent. It does not trash, it does not dissect. Here's another patient. This is an 80-year-old male with a history of coronary artery disease, previous TAVI, heart failure. He's got a very rapidly progressive ulcer following a small blister to his foot. You can see this long SFA lesion with heavily calcified stenosis, and again, a very poor runoff. In this case, I'm going to be worried if I do atherectomy that I'm going to trash the single vessel runoff and leave him in a worse situation than I find him. So we use IVL here. We get a really good result. Because of the clinical status of the patient, I make a primary decision to place a stent, and you can see the superior stent looks great. I always used to say to my trainees, if the superior looks this good, it means that you've undersized the stent. But actually with IVL, we can get this kind of result with a proper sizing, and it's a really, really safe and effective vessel preparation for the superior stent. And you can see these final angiograms. There's no trash at all, excellent flow to the foot, and the ulcer is now almost healed. I'll leave you with one final case. This is a 64-year-old male, diabetic with a necrotic hallux. You can see this focal occlusion in the popliteal artery, as we were talking about before. This is what we call a no-stent zone. I particularly don't want to stent the popliteal artery in a 64-year-old guy who's essentially otherwise healthy, active. I know if I put a stent there, it's going to occlude quickly. You can see the IVUS image, a tightly calcified stenosis. I have to do a little bit of pre-dilatation to get the Shockwave balloon through, but you can see this very, very pleasing result with the intravascular ultrasound and excellent flow on the final angiogram, again, without having to stent, without having to cause a problem to the runoff. So I'll just leave you with this data, which was presented at Viva last year. IVL shows very, very consistent outcomes across multiple vessel beds, lesion types, and specifically in critical limb ischemia patients who are the most at risk and the most difficult to treat. This is making life a lot less stressful for all of us. Thank you very much.